Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you are aware, we have a YouTube channel where the videos of all lectures are available. You can easily access them when and where you want. We also have a Telegram group where the PDF which you can join to access all lecture related information. We have a Google Drive where the PDF of all lectures are available and a master integration key which coordinates between the YouTube channel as well as the PDF. These are the disclaimers, and we are with phase 3, which is recorded pathology lectures. And today we are with Pursue 3L, which is soft tissue and bone tumors. And the topic of the day is approach to cartilage forming bone tumors. To talk on that, we have Dr. Bhaskar Mitra. He's an MBBS from Calcutta, MD, DNB, gold medalist, a consultant histopathologist at the Tribedi and Roy Diagnostic Lab, Kolkata, with multiple publications in index and national and international journals. With this, I would request Dr. Bhaskar Mitra to start his lecture on approach to cartilage forming bone tumors. Over to you, sir. Thank you.
Good morning, everybody. I am Dr. Bhaskar Mitra. Now started to present my fourth lecture in the row about the bone tumors. Okay. Now today I will be talking about the cartilaginous tumor and how it forms and what is the pathogenesis, and also discuss about the different type of cartilaginous tumor. So in the bone pathology today my topic is on the cartilage forming tumor or the chondroid tumors. Okay, so the chondroid tumor means there is some amount of cartilage is present everywhere or somewhere in the tumor. So now our point of this discussion or this class is to discuss how this cartilaginous tumors forms and how it looks like. Now these are the most common cartilage forming tumors. These are the osteochondromas, chondromas, chondroblastomas, chondromyxoid fibroma, and obviously the malignant part among this is the chondrosarcoma. First of all, I like to discuss these things. How will we approach to these cartilaginous tumors or the chondroid tumors? Now, the base rules of the bone tumor first to see is the radiology. So first we have to see the radiology and take the opinion of the radiologist what they say. Whether this lesions has got a benign radiological features, means whether the lesion is well circumscribed situation and the characteristics of radiologically signifying that the lesion is benign one. Then we have to divide those lesions into the following category. Suppose it's a benign cartilage producing tumor with the benign radiological features having a surface cortical thing with a peduncle presented as a pedunculated mass. If we get a section, we will see there is a cartilaginous cap above it. Below it there is a ossified area showing the endochondral ossification type of thing with having a hyaline cartilage cap. So there is both presence of cartilage and the bone there. So we consider that as the osteochondroma, the bone osteo and the chondromas. Next comes if it presents with a benign lesions with a epiphyseal lytic areas, and we see a cellular thing having lots of cell lying within a chondroid matrix, and in the radiologically there are chicken wire calcification in these tumors. Then we term this as chondroblastomas. It looks like small round cell tumor throughout the thing, and if we do immunohistochemistry, these tumors are usually S100 positive. Now comes about the medullary lesion. If we find again a chondroid lesion with a benign radiological features and situated in the medulla, if it's a well-defined lucent lesion, and in the section we get only the benign hyaline cartilage, we consider that as enchondroma or chondroma. If it has a metaphyseal location with a lytic areas and scalloped margin, and in the section we see lobulated, both myxoid and the chondroblastic, that is the cellular area appearance. Then we term it as chondromyxoid fibromas. So both chondromyxoid fibromas, these are very easy to differentiate. So it's a benign radiological feature showing both bones and cartilage together. It's osteochondroma with a characteristic pedunculated mass-like appearance. If it is a epiphyseal lesion with a loss of cell lying in a chondroid background, then with a chicken wire calcification, it's chondroblastoma. Only mature cartilage-like tumor, then it's enchondroma or chondroma, and cartilage along with the myxoid fibrous component, then we term it chondromyxoid fibromas. All four are benign lesions. Now, if you see in a greater view, this is a polypoid mass with a cartilaginous cap above. It's a polypoid mass with a hyaline cartilaginous cap above. Beneath it, there is a bone forming areas. This is the polypoid cartilaginous mass. This is osteochondroma. This is chondroblastoma. It's a more cellular with a chondroid areas in between, and it's a full of cells and cells. And here we can see a fair number of giant cells also. So in chondroblastoma is in other way, it's a giant cell containing lesion. So any cartilage tumor having a giant cell component within it, we have to think about the chondroblastomas. Now coming to, if we see only, it looks like a simple normal cartilage showing the lacunae containing the chondrocytes. Then it's the enchondroma or the chondroma, and the cartilage along with the fibromyxoid areas, that is the myxoid background in which the fibrous cells are there, also the cartilage cells, then it's chondromyxoid fibro. In both the cases, there the cells looks like very benign, and they are very benign, lacking atypia or the mitotic activity. Now compare this tumor cellularity with this tumor cellularity. Definitely the cellularity is much increased with the cells showing more atypia and the malignant features. This is the chondrosarcoma. This is how it differs from a benign chondroid tumor into the malignant chondroid tumor. The cellularity, atypia, mitotic activity, all the things are much higher containing to a benign counterpart of this chondroid lesions. Now I am going one by one to each of these things. First is the osteochondroma. Commonly we know this as exostosis. It is a benign cartilage capped outgrowth attached to the underlying bone. Okay, it may be single, it may be multiple, or it may have a hereditary component. It's a slow growing tumor and having a painful when impinge over the nerve stalk or having fracture. And it's epiphyseal growth disturbing things, and it causes disturbance in the growth in the epiphyseal, or what we can say, it's a misdirected growth of the bone from the epiphysis. It is maybe solitary, multiple. It's more common in the males. Site is metaphysis of the long bones, especially around the knee areas. This is the mushroom shaped outgrowth from the surface of the bone. Okay, it outgrows along the misdirected areas with a cartilaginous cap above the thing. Here in the radiology we can see this is the misdirected polypoid-like lesion. This is the misdirected polypoid-like lesion. So what we can see is the bone is growing in this way and it's growing in another way. So there is a defect in the growth direction, as the bone supposed to grow in this way, but it is not growing, it is growing in another way. It is a misdirected bone growth, what we can say roughly to this. This is in the tibia showing osteochondroma, polypoid mass areas. Now this is the characteristics in the histology as we discussed previously. It's characteristically showing a hyaline cartilaginous area above and a ossification below. If we see, there are two types of ossification in the bone. One for the flat bones is the intramembranous ossification, and for the long bones is the endochondral ossification. In the endochondral ossification, there is a cartilaginous scaffold which is gradually get ossified and forms a bone. Here lies the junction of both the hyaline cartilage and the bone beneath it. So we can see the hyaline cartilage above, the new bone formation beneath the hyaline cartilage, and below this there are trabecular bone with the marrow spaces containing fat or hemopathetic marrow as per the age of the patient. So it's the osteo and the chondro both combining together forming the osteochondromas. Now comes the chondromas. It's a benign tumor composed of hyaline cartilage. In chondromas, it is usually seen in the medullary cavity. It may be subperiosteal or juxtacortical axis, or sometimes we can see soft tissue chondromas also. Now, this is a intraosseous cartilaginous tumor. In the bone, there is a cartilaginous tumor. It's a solitary lesion, more common in 20 to 50 age groups. It's a short tubular bones of the hands and feet are the most common, and it is in the metaphyseal region. If there is multiple enchondromas, there is a disease, syndromic association that is called Olier's disease. And this enchondroma may develop into the chondrosarcoma in 25% of the patients. Maffucci syndrome is the enchondromas with the soft tissue hemangiomas. There is a malignant transformation is much common in the Maffucci syndrome cases. These are the syndromic association of the enchondromas. Now regarding the clinical features, it's a painful mass as there is a cartilage in the bone, so there is a weakness, so there is a pathological fracture. And there is a O-ring sign, that is a well demarcated radiolucent lesion. We will show you. This is a typical radiological finding of enchondroma. Here we can see there is a well demarcated myelodrillan line, a lytic lesion here. Here we can see well demarcated lytic lesion. It may be subcortical, where we can see part of this well demarcated lining, or saucerized well demarcated cortical lucency, what we say. Now, this is what we said, it's a cartilaginous tumor within the bone. So there is a bone in between, there is a cartilaginous area. During the glossing, we can see, while we cut the bones, we see these glistening cartilaginous areas. So it is a well circumscribed lesion containing hyaline matrix and benign chondrocyte within the loci. There may be ossification and calcification, and usually they are hypocellular, but it can be hypocellular resembling very close to grade 1 chondrosarcoma, and that is very difficult for us to differentiate. In the microscopy we can see this is a benign cartilaginous area. The chondrocytes are there present within the lacunae. We can say that there is a single lacunae, there is a single chondrocyte, and the cellularity is much lower. Here we can see these are the different varying amount of cellularity we are showing. Here the cellularity is much lower. In the higher part there is a less cellularity. This is again cellularity, but this is a bit more cellular than compared to this one. So these all are enchondromas because there is a lacking, the cells, chondrocytes lacks the cellular atypia or the malignant features, or also the mitotic activity. Again the chondroma, this is the cartilaginous area we can see, but look at the cells, cells are very small, pycnotic nucleus, no cellular atypia, no mitosis, but cellularity is there. This is the hyaline cartilage. In the histology, this is the classical picture of enchondroma, or what we say chondroma. This is the multiple chondromas in the case of Ollier syndrome or Ollier disease. Now comes the chondroblastoma. As we said earlier, this is the more cellular component. It's a rare tumor seen among the young adults, and particularly the epiphyseal in location, particularly the greater truncator of the femur is the common site. Morphologically, there is polyhedral sheets of chondroblast with well-defined borders. Let's have a look at the picture. Now first the radiology. Again, it is extremely well demarcated benign lesions. no irregularity in the margin, well scalloped margin, and there is a surrounded by a dense bone sclerotic border. So this is significance of a benign radiological feature of a chondroid lesion. Now, in the histology, this is a cellular tumor having polyhedral cells. Here, if we see very carefully, we can make out the cell border of each of the cells. So, this is the chondroblastoma. This is a benign looking cells, but the cellularity is much higher compared to the enchondroma or the osteochondroma there. And along with there may be small strings of ossification, what we call the chicken wire ossification or chicken wire calcification in the whole tumor. And as I said earlier, this is a giant cell containing lesion. So we also get a clear giant cells component in the cells. So giant cell containing lesion with a cartilaginous radiology and histology, we term this as a chondroblastoma. This is very distinct character. Here is a well demarcated individual chondroblast can be seen. As we say, these are the chondroblasts, not the chondrocytes. So they are not present in the lacunae, they are present in good numbers, and there are the chondroid areas. So previously in enchondroma we are seeing the chondrocytes, and these are the chondroblasts. So chondroblastoma. Again, there is a cellularity is a bit low, but again background there is a cartilaginous area with a well-defined border of the cells, and it is showing the fine chicken wire calcification. And surrounded by there are some of the cells showing a bit of degenerative changes. These are the degenerative cells along the chicken wire calcification. Again, the chondroblastic cells, here we can directly make out the individual cell border. The cell border is very prominent. We can say see the boundary of each of the individual chondroblast here. The giant cells are there, and these are the chondroblast. This is the classical picture of chondroblastoma. Next comes the chondromyxoid fibroma. So as I said that from the name suggests it's a chondroid area and the fibrous area both together is there. So it is also present in the long tubular bones. It's a well circumscribed glistening grey tumor. Microscopically there is a nodules of hyaline cartilage with intervening myxoid tissue and osteoclast-like giant cells. So this is the chondroid area, and here we can see the fibrous tissue with the myxoid component, the elongated fibroblastic cells. The chondroid tissue is surrounded by there. There is maybe presence of osteoclastic, again a presence of osteoclastic giant cells, but the cellularity is much less. The chondroblasts are not seen very together. So this is a combination of both the chondroid and the fibromyxoid areas. So this is the case of chondromyxoid fibroma. So this is about the benign part. Now we are moving from the benign to the malignant part. So now if we get a chondroid producing bone tumor with a malignant radiological feature. Malignant radiological features means there is a lytic lesion with a cortical destruction, epiphyseal cortical lesion. Along with the cortical destruction, there may be combined lytic or radiodense lesion there. So a prominent cortical destruction suggests the malignant radiological features in the chondroid tumors. So if it is a lytic with a cortical destruction and it's an axial proximal skeleton lesion with the presence of fair number of atypical hyaline cartilage cells with the myxoid changes. Here we can see it's more look like an enchondroma with a much cellularity, and the cellular nucleus become more prominent, more hypercellular, hyperchromatic, and showing cellular atypia. So this is a chondrosarcoma. It of different grade. Here it is shown is a low grade chondrosarcoma. It may be higher grade. There may be presence of a fair number of sheets of clear cells embedded in the chondroid matrix. It is again a malignant features with the radiology. Again it's a chondrosarcoma with a clear cell appearance. Again it is a S100 positivity can be seen. So this is clear cell chondrosarcoma. There may be presence of Metastatic tumor, which shows the glandular appearance, again showing the chondroid, again showing the similarity like radiological picture of the chondroid cells. But these are the, as this is a metastatic carcinoma, we can see the cytokeratin positivity among these cells. Okay, so clear cells may be coriace cell chondrosarcoma, or it is chances of that may be a clear cell carcinoma being metastatized in the bone. Now, if there is a combined lytic and radiodense lesions with showing variable sarcomatous pattern along with the chondroid differentiation with a clear transition zone between the chondroid and the sarcomatous pattern, then we term it as mesenchymal chondrosarcoma. And there is a no transition between the sarcoma and the chondroid zone. It's a mesenchymal chondrosarcoma, and the dedifferentiated chondrosarcoma, we can see the clear transitional zone between the each of the two. Okay, so this is the mesenchymal chondrosarcoma. This is a much cellularity with the chondroid areas with a less transition areas, and here is the dedifferentiated one. We can see the clear line of demarcation between the sarcomatous component and the chondroid area. So this is dedifferentiated chondrosarcoma. Here the cellularity and the cellular atypia shown by the chondrocytes is much higher. Now this is a clear cell chondrosarcoma showing the clear cell sheets up. Again we can see the giant cells here in the clear cell chondrosarcomas. Look at the important key point in these tumors are the look at the cellular atypia and the malignant feature of the individual chondrocytes. Again, we are showing in the middle, this is a benign counterpart, the inchondroma. Look at the nuclear and the cell character. Now you see the chondrosarcomas. And this is the grade 1 chondrosarcomas. It is again grade 2 and it is grade 3. As the grade increases, the cellularity also increases, the cellular atypia, mitotic activity, or even the malignant appearance of the tumor is much increased as the grade increases from grade 1 chondrosarcoma to grade 3 chondrosarcoma. So here we can compare how the benign and the malignant chondroid tumors look like. So chondrosarcomas comprise of a group of tumors with a common feature being production of a neoplastic cartilage. It is a higher age tumors more than 40 years with a male predominance. The pelvis, shoulder, ribs and the tubular bones of the limbs are more commonly seen to be involved by this chondrosarcomas. It may be intermedullary, that is the central one, juxtacortical surface one, or there may be extraskeletal soft tissue chondrosarcoma, especially the mesenchymal type. So there are the conventional, the myxoid or hyaline cartilage type. According to histology, there is a clear cell, dedifferentiated, and the mesenchymal chondrosarcoma. Sometimes there may be oligoid disease in chondromas transforming into the chondrosarcoma. Conventional ones around the pelvic girdle, even we can see in the nasal or laryngeal bones involved by the chondrosarcoma, but the small bones of hands and feet are not involved, which is more common finding in cases of uncontrolled. The radiologically we can see it lacks a well differentiated well demarcated margin. It's a lytic sclerotic lesions with sometimes there may be cortical destruction or cortical expansion. This showing a expansion of the tumor with permeation of the tumor into the surroundings of tissue. Again there is a calcification there within the tumor suggesting this is called spotchy calcification, commonly seen in case of chondroid tumors. But look at this radiology. In radiologically, it also looks a more aggressive tumor than the previous benign counterparts. When we cut the tumors, we will see glossally the large bulky tumors with the cartilaginous area, and the cartilaginous tissue sometimes may show in cartilaginous the break in the cortex with a permeation into the surrounding soft tissue. Look at this cartilaginous. These are very fleshy, glistening bit of angry looking tumors we see while we gloss the specimen. This is the gloss looks of the chondrosarcomas. Okay, it involving the marrow spaces here, pre-existing bony tuberculi. The cortex is eroded and thickened in some of the places. Here we can see the thickened and eroded cortex in the surrounding tissue. Now this is the high-grade chondrosarcoma, the conventional one, where we can see hypercellularity, scattered chondrocytes with a plumb vesicular nuclei and the small nucleoli. Some of them are binary nucleated with a low mitosis rate. There the cellularity is increased. The chondrocyte as per lacuna is much increased. Gradually, as the grade goes up, the cellularity, atypia, mitotic figures become more evident and more prominent among the cells. Look at this. These are the cellularity much increased. Here the cellularity is much increased compared to this low grade. This is a high grade chondrosarcoma showing much atypia among the cells of the chondrocytes we can see. Now comes the dedifferentiated. It is a mixture of both low and the poorly differentiated high-grade sarcomas. It may be spindle cell sarcomas, fibrosarcoma, osteosarcoma, any type of high-grade tumor with a side-by-side presence of chondrosarcoma benign, the low-grade one. So this is called dedifferentiated chondrosarcoma, where the chondrosarcoma is changed from one to another one. Now the clear cell chondrosarcoma, here we can see the clear cell chondrocyte. It almost looks like, if we tell this is a metastasis from a clear cell renal carcinoma, it is very difficult. For that case you need the immunohistochemistry and the proper history to differentiate this is a clear cell chondrosarcoma from a clear cell metastatic tumor, what I have already discussed. The cytokeratin positivity will help you out on this. These cells are usually arranged in small lobules, and there may be presence of osteoclastic giant-like cells along the edge of the lobules. There may be woven bones or the trabeculae of bones at the center of the lobules, and there is a centrally placed nucleus among all the cells with a clear abundant cytoplasm. Now comes the mesenchymal chondrosarcoma. One third of these cases are we see in the soft tissue counterpart. Among the young bones, young adults, jaw bones, ribs are the common thing. There are islands of well differentiated hyaline cartilage we can see, surrounded by sheets of round blue cells having a hemangiopericytomatous blood vascular areas. Here we see the undifferentiated area, the small round cells. These are the chondrosarcoma cells, and with the presence of a benign hyaline cartilage on one part of the tumor. So actually what we see a biphasic pattern in these tumors. Next comes the myxoid chondrosarcomas with the abundant, it's a chondrosarcoma conventional one with the abundant myxoid substance in the soma. So one at the areas it may be cellular, there may be monotonous small cells arranged in sheets and cords among the myxoid chondrosarcomas areas. And there is a deeply eosinophilic cytoplasm and the vesicular nucleus among the cells and the prominent myxoid background throughout. Prognosis of the chondrosarcomas, if it's more than 10 centimeter, is a very poor prognosis. 5-year survival in some of the low-grade ones are very high, about 90%. There is a chance of metastasis there. It's a painful, progressively enlarging tumors, and there may be metastasis or spread may occur into the lungs and the other skeletal tissues. Now comes the most interesting part of this chondroid tumors, that is the molecular pathogenesis. How in the molecular way we can explain the growth of this tumor. Now to understand this we have to first to know how the cartilaginous areas grow in a bone. So first question to me of mine is to all of the students and persons listening is where we can see normally the cartilage in the bone. We can see the cartilage in the bone in the growth plate or the metaphyseal plate. So if we go to the basics about the individual structures of the bone, so there is epiphysis, there is a growth plate or cartilaginous plate, because this is an endochondral ossification going on, and beneath it there is a metaphysis and this is the diaphysis. So in the metaphyseal region we got the growth plate. So if we see the growth plate, there is a different things in the growth plate. There is a group of cartilage growing from one end to other end with a proper maturation and surrounded by a perichondrium. So if we see the growth plate in an individual schematic way, one side there are resting chondrocytes. Above that there are proliferating chondrocytes. The chondrocytes are proliferating and moving towards up. And there is a pre-hypertrophic chondrocyte because there is increase in the number and now it starts the increase in the cell. So there is a hypertrophy going on among the chondrocytes. So there is a hypertrophic chondrocyte followed by this. Now, when there is a pre-hypertrophic chondrocytes are there, they secrete a material called Indian hedgehog signaling material. This material goes into the stroma with the presence of proper direction by the heparin sulfates. It diffuses into the stroma and goes to the perichondrium, and its direction is determined by the two molecules called extocin 1 and extocin 2. So Indian hedgehog signaling material goes to the pericardial chondrocyte, pericardial region, and the pericardial cells, they form a PTH-like hormone secretion, and that causes stoppage of the differentiation of the chondrocytes and chondrocytes die. So it's a self-destroying or self-inhibiting chondrocyte pathway which maintain the direction and the chondrocytic differentiation. So for the proper maintenance of the cartilaginous plate, as the chondrocyte grows, it secretes its own inhibiting factor, Indian hedgehog factor, which causes the back feedback release of parathyroid hormone like hormones, which stops the differentiation. Once the chondrocytic differentiation is stopped, the hypertrophic chondrocytes, there is a perivascular cell infiltration among the chondrocytes, and gradually it gets ossified, forming by the osteoblast and the osteoclast. They causes the bone forming and the bone remain. So if there is a defect in this pathway, that would, this is the pathway, and if there is a defect in this pathway, suppose there is a hedgehog activation, but this hedgehog activation remains as there is a problem in the receptor, in the PTH LH receptor. So the feedback loop will not occur because the PTH LH secreted by the Indian hedgehog signaling will not act on these things. So chondrocytic stoppage of differentiation will not be there. So the cartilage will go on going like this. So we will find a cartilaginous island within the bone, and that forms the enchondromas. Now what we see, it is with this. So we see the cartilaginous tumor within the bone. It's the cartilaginous area, it grows within the bone, and because of the hedgehog receptor pathway defect. And what we say, this is the Indian hedgehog material, it diffuses towards the perichondria with the help of a molecule called exostocin 1 or 2 molecule, which with the presence of heparin sulfate helps the diffusion of Indian hedgehog genes. Now, if there is a defect in this exostocin 1 and 2 mutation, so this pathway of direction of things will hamper. So there will be misdirected accumulation of this chondrocytes. But as the PTH-LH receptor is working, so there is a proper formation of a bone, but the bone will be misdirected one. As I said earlier, in the osteochondroma, it's a bone growth in a misdirect fashion. This is how there is a misdirected bone growth occurs from the long bones. So this is the osteochondroma, how it's formed. It is the so main reasoning is that mutation in the exostocin pathway. Now gradually the other things started growing on this cartilaginous tumors. One, the two pathways where there is a hedgehog activation with a defect in the PTHLH, sorry, PTHLH receptor, and there another one, there is a defect in the hedgehog diffusion process. So both causes the formation of a cartilaginous tumor, one within the bone and one in a misdirected. And now comes the secondary events. As we know, the neoplastic thing is a multi-step process. So there may be gradually P53 mutation, IGF mutation, COX2 mutation causes more and more accumulation of the mutation, neoplastic mutation within the things. There may be on the other way, there may be PTH-LH receptor defect or maybe COX2 inhibition again in the osteochondromas. So cartilage cells become more neoplastic, and gradually there may be other things like AKT pathway defect, SRC defect, there may be HIF, hypoxia inducing factor defect, and MMP, that is a defect in the matrix metalloprotease thing that confines the growth of the cartilage and the bones. If there is a defect on this, that will lead to the abnormal formation of this neoplastic chondrocytes. Among this, the P53 again is there. So as the starting pathway is the hedgehog activation and the diffusion defect, gradually it, along with the other molecular factors like P53, IGF and COX2 inhibitors, HIF inhibitors, there is a malignant neoplastic proliferation among the chondrocytes. Okay. This is the whole thing written here for the easy remembrance of the students. So that makes what are the different chondrocytic tumors and its molecular pathogenesis and how it forms and how it looks like. So this is about the details about the cartilage producing tumor in the bone. In the next, I will come with the more things like a giant cell containing bone tumors or with the small round cell tumors which occurs commonly in. So this is the cartilage producing tumor. This is the misdirected osteochondromas. There may be chondromas. So this is the cartilage producing tumors what we studied today in details. So thank you for everybody for listening my whole presentation and the lecture. Hope it helps you all. Thank you. Thank you to everybody and especially to the Pursue team to giving me opportunity for this platform to present these lectures to all the students. Thank you all of and thank you to Nadim sir also. Thank you.